Hello, everyone, and thank you for joining us. My name is Sharice, and I am a board member here at NAMI, Maryland. I will be the moderator for our webinar today, and I'm also joined by NAMI Maryland's Community and Provider Education Coordinator, Mackenzie, who will be assisting us as needed with technology and our Q&A at the end of today's webinar. The lack of mental health crisis services across the U.S. has resulted in a need for first responders to serve in mental health situations. It is important for first responders to form effective strategies and partnerships with local mental health services. Today, we are hosting two guests, Lieutenant Stephen Thomas and Steve Plummer, who will explore the intersection of first responders with mental health care and teach us how to develop effective strategies to build strong partnerships, to ensure access to quality treatment, and increase awareness around the needs of mental health care for first responder professionals. Before we get started, we wanted to note a few housekeeping points. To avoid background noise, all participants will be muted for the duration of the webinar. We will be addressing questions at the end of the webinar. If you have any questions as the webinar continues, please enter them into the question box, which is located on the right side of your screen if you're viewing from a computer, or the bottom of your screen if you're viewing from the phone. We will be reviewing questions as they come in, and if there's something in particular that is unclear or needs to be expanded, we will ask our speakers to do so when the question is asked. If you have any comments or concerns during the webinar, please also enter these into the questions box. We will review and address any immediate needs as they occur. A recording of this webinar will be emailed to each registrant tomorrow. The recording will also be available on our website at namimaryland.org for any individuals that were unable to register. 1 hour of CEUs are available for Maryland Police, Corrections, and EMS professionals. Individuals pursuing CEUs must attend the whole webinar and submit a survey that will be presented to you at the end of today's webinar. A certificate of attendance will be sent to each registered participant tomorrow afternoon. After the webinar today, you will be asked to complete a short survey on the aspects of this webinar that you felt were helpful, could have been improved, and what you would like to see in future webinars. Each person that completes the survey will also be entered into a drawing to win a $25 Amazon gift card. Yay! This is the only one of webinar in a series of educational webinars that NAMI Maryland plans to host. We plan to host 3 more webinars in this series between now and April, surrounding topics of creating peer support team, cumulative trauma, and compassion cultivation. We ask that you please fill out this survey to let us know how NAMI Maryland can best support you during this time. We want to hear from you. So now I'd like to introduce and welcome our speakers for today's webinar, Lieutenant Stephen Thomas and Steve Plummer. Lieutenant Stephen Thomas has a BA from UMBC in Political Science and Sociology, and an MA from the University of Baltimore in Legal and Ethical Studies. He started as a patrolman with the Anne Arundel County Police in 1996, where he remained in patrol until he became the CIT and Peer Support Coordinator in 2016. In 2020, the Anne Arundel County CIT unit was named CIT International's CIT Unit of the Year. He is the Anne Arundel County ICISF, which in short is International Critical Incident Stress Foundation, what a mouthful, CISM, Critical Incident Stress Management Team Coordinator. Further, he is an ICIS approved instructor, and in the spring of 2019, he received the ICISF Pioneering Award at their World Congress. He is a youth and adult mental health first aid instructor, and at the 2018 Mental Health First Aid Summit in Washington, D.C., was named a top instructor. In 2019, he was awarded PAARI which stands for Police Assisted Addiction Recovery Initiative Leadership Award, for his role in developing and implementing Anne Arundel County's Safety Station Program. Thank you, thank you, thank you for all your work, Lieutenant Thomas. Steve Plummer, LCPC, graduated from Loyola University, Maryland, with a Master of Science in Counseling Psychology and is a licensed clinical professional counselor in Maryland. He has more than a decade of experience specializing in treating first responders and trauma-related disorders. Steve has worked in many different settings, including hospitals, behavioral health care clinics, police-based crisis programs, and outpatient private practice. In addition to his clinical work, Steve provides training and consultation for law enforcement in mental health, stress, resiliency, and 40-hour crisis intervention training. His treatment and teaching philosophy includes bringing practical application, humor, and compassion to his work. Thank you both for joining us today. Now, let's get started with our presentation.
Thank you. Glad to have everybody here today. As we get started, I'll just kind of outline some objectives for our training today. We want you to get an understanding of how we came to be here today, the two of us together, and our story about how we got here. We're also going to talk about the differences and similarities between therapists and first responders, because that's really going to highlight why there is such a gap in first responders seeking help. You're also going to understand how what are some of the key elements of the culture that also provide barriers to seeking treatment, and then really dive into what the strategies are and how we developed our partnership. Additionally, where we've gone wrong and where we've had to kind of make up for that, what we kind of see are the best ways to achieve a good working relationship, and kind of, you know, what our thoughts are about moving forward with this relationship, what I hope for, not just for us, but, you know, for the future of working with first responders and mental health care. You got a pretty good background on both of us through our opening there. Thanks, Therese. Again, I have a master's in counseling psychology. I've been practicing for 11 years. I actually come from a law enforcement family, which I thought, you know, gives me a good solid base for some of the work that I've been doing. I didn't always know that I wanted to work with law enforcement when I first got into the field. I was really more driven towards doing crisis work. It was really more of the work in crisis that kind of pulled me in the direction that I'm in now. I don't know if you want to say more about how you got to where you are.
So I started in the Baltimore City Sheriff's Office, then lateral to the Anne Arundel County Sheriff's, and then again to the police department. I think it's important for my educational background with legal and ethical studies is sort of the history of philosophy along government, where I have a different approach to what policing is and an understanding of what we do. And it's really, how do we help? How do we become we're part of the community? Finding when there's criminal behavior, it's finding the root cause of that behavior. But it's more than being a police officer, it's being a peace officer and recognizing from that the effects that it has on us as police. And there's times we're going to need additional help. And part of that's also through the training I received through my CISF and being a instructor for CISM, the critical and stress management, and having the understanding of our jobs are very, we suffer a lot of trauma. Yesterday I was responded to the suicidal death of a 14-year-old. How do we help that family? How do we help that child who's deceased peers? But then how do I help myself after that? How do I help the officers that were on scene? And it's really important to recognize that those calls do have an effect on us as police.
Thanks. So I like to start with these slides here because I think it does a really good job at kind of examining the differences between first responders and therapists. Excuse the formatting a little bit. And I didn't make up this myself, I actually got it from a book. Most therapists you'll find are from a middle or upper class background. We have to have a graduate degree in order to do our work. Generally, because of that, we start families or careers a lot later. You're not going to find most of us have military experience. They tend to be a lot more liberal. Violence is not something we've encountered a whole lot. Definitely more non-directive, contemplative type of people, and we kind of see through things lens as a world of possibility. Again, these are broad strokes. I'm not saying all therapists are like that, and I'm certainly not saying all first responders are like that. But you know, on the flip side, you'll find that generally most first responders might come from a working class background. You know, high school diploma. They start their career at 21. Many of them do have a military background. Definitely tend to see more conservative on the political spectrum, and again, they're more prone to having violent encounters, physical, action-oriented type of work, and teamwork, conformity, predictability, and many of their interactions are really based on their past experiences. And so those are sort of some of the kind of, again, broad strokes, stark differences, I would say, between mental health professionals and first responders. And then on the flip side, here's how we're all alike, which I find to be really interesting. We both want to make positive differences in others' lives. I can't say I've ever met an officer who didn't feel that way. They work on relieving suffering on both sides. We're both in positions of public trust. We often have to work in the same kind of bureaucratic structures. Burnout and compassion fatigue exists in both of our careers. And you know, we're often objects of stereotypes as much as police are. And you know, oftentimes you'll find that there is some sort of history of conflict or mistreatment in families in the past that may have shaped or influenced their decision to go into the career path. So I highlight this because one of the problems is there's difficulty to engage first responders in receiving mental health care. And while some of those differences that exist between us are pretty stark, we're actually a lot more alike than we think. So I always like to kind of make sure that people understand that. Okay. So again, this is another sort of broad generalizations. You're not going to find that some of these are you know, facts, but some of them are just, they're not every first responder. In general, those who choose a career in being a first responder have 10 years less lifespan than the general population. They are 4 times more likely to develop PTSD than the general population. It is a fact that there's a higher rate of heart disease and higher probability of conflict in relationships. Certainly financial stress is a lot of it, as well as, you know, problems with the work. 1 in 4 first responders will report having suicidal thoughts at least once in their lifetime, and tend to be more difficult to engage in treatment. I will tell you that I had somebody talk to me one time when I was giving this lecture about how I assumed their spouse was a first responder, and argued with me about how you know, law enforcement or whatever don't, you know, her husband didn't drink, he didn't go to the bar after shift for shift parties, and he always came home, and he didn't have struggles with you know, interpersonal relationships. So again, I'm speaking in broad strokes, but these are some of the kind of common themes I've seen, at least in my practice, and some of the research that's been done in treating first responders over the last few years. You're definitely going to find more of that adrenaline addiction among the culture, as they're kind of chasing that high of the excitement from the work, which can also lead to certain problems in their personal life. Okay. So how did we get together? How does this partnership work? Really, what we're discussing here isn't anything that's profound or you know, earth-shattering, I think, by any stretch of the means. It's honestly an accident of timing and opportunity. I began working on the mobile crisis team here in Anne Arundel County in 2009, and we were a police-based mobile crisis team. So what that means is the police go on calls, they're the first response, and then if there's a mental health crisis or some other social emotional issue that occurs, that they will contact a team of clinicians to come out right away, and so to help with the situation. So what I found was we would go on lots of different kinds of calls, not just people with mental health crises, but people who are involved in a critical incident. If there was a traumatic death or any kind of death, we would go to do on-site counseling with people there. And what I found in that work was not only was I providing counseling and crisis counseling to the people on scene who had experienced the event, was at various points in time, I had an officer pull me aside and say, "Hey, I'm not doing well with this. I need to kind of talk about it." And I can think of two pretty specific examples. One was a DOA, dead on arrival of an infant, of a child, and which affect all of us, especially those who have children, very personally. And I had an officer outside the Ambo Bay at the hospital who was just in tears. And I kind of went over and just kind of struck up a conversation with him. And he had 2 small kids himself, and so he needed to sort of vent in that moment about kind of what he was experiencing, because he was having a lot of transference with that situation. I have another example. I went to we used to go to roll calls. So when officers start their shift and they're giving out post assignments and kind of what to look out for that day, mobile crisis team will go just say, "Hey, we're here. What's going on? Is there anything we need to be aware of? How can we help you today?" And I had an officer pull me out into the hallway and said, "Hey, I'm having a lot of trouble with my kid. I don't know what to do. What should I do?" So I had found through the work of doing mobile crisis, where we were already embedded here. The mental health piece was already in existence. And because of that, because we come and help the officers on scene, there was this implicit trust, like you're one of us in a sense. And because of that, they felt more comfortable, at least I assume, asking us about how to help each other. And so that's really how I kind of got into wanting to help law enforcement, at least at that junction. And then comes, specifically in Anne Arundel County, the development of CIT and peer support. And I don't know if you want to talk a little bit about that.
Excuse me. So yeah, in 2014, we really took it a next step, and we truly have fully integrated law enforcement and mental health. But we sort of did it in a different way. So Jen Corbin, who is my partner, is the director of crisis response. She's also a social worker. And her vision back then was the full integration, but instead of putting mental health into the police department, we put police officers into the crisis system. And there is a difference, but with that, it's developing a culture of helping. It's developing the relationship that when that officer needs assistance, they're comfortable reaching out for help. It's also part of, we treat our officers the same way we expect them to treat the community. We can't expect the officers to have empathy for the community with mental health concerns and after a traumatic incidents if we're not doing the same for the officers. So with that, it's the natural progression that when we created our CIT unit, we also created our peer support team. And that's when I started going to training to become a CISM trainer. And then the positive outcome. And what I mean by that is, we've had incidents. We had one specific incident that was a murder-suicide that was pretty outrageous in the community, that one of the primary officers was already seeing Steve. First thing when I walked in the door, and I knew he sees Steve regularly, and he was like, "I've already called Steve. I got an emergency appointment tonight." And he started encouraging the other officers that were on scene with him to do the same. Now, we're there and trained in CISM and to be there for that support. But in certain circumstances, these incidents are really, really tough. The best thing we can do is refer. And that's part of what we do when we follow the models of CISM, is recognizing when do we need to refer somebody and when don't we. But when some of these incidents are as powerful as they are, Steve's a great help and an asset to our department.
Yeah, so when they develop peer support, that's really our first line of defense in helping officers and first responders within the department. Was we found that it's easier to talk to people like yourself, right? So that would be we trained several officers in the CISM model and how to talk to each other, and we created an entire policy on how we use peer support, and there's confidentiality that's involved. All the officers who do it are bound by confidentiality, with the exceptions of where they must intervene. And because of that, it became this sort of again, small cultural kind of shift where it's okay to talk to this person because they have training and I need to talk about it, and I know they're not allowed to talk to other people. And so what happened from there is now we have a bunch of peer support officers who are talking to people, and now they've reached their ceiling, right? Because they're not clinicians and they need to be able to help refer people out to the next step. And that's kind of where I came in. I had been working in private practice at that time, sort of always with the goal of treating first responders, but it wasn't, what I went to the practice to do necessarily. And then, one of the peer support officers was like, I need to meet with this guy. I want to talk to him before I just send somebody there. Because again, there's this sort of level of mistrust with mental health. There's also a lot of stigma that goes around that if you see a therapist, that as a law enforcement officer or as first responder, that you're not going to be allowed to work, that I'm going to put people out of work, that I'm going to take their gun away from them, that all of these sort of things that are, not necessarily true. And so I met with him and he deemed that I was okay. And he sent me my first client, who was actually the client that Steve was just talking about. And it kind of built from there. And so what happened from that point was obviously that officer told other officers, encouraged them, and then I started seeing more. And then before you know it, now my name is kind of circling around the department and my practices. And then really what kind of moved on from there was doing more relationship building. So what I found was in order to kind of get the buy-in from the police department is I need to be here. And that's actually where we're now. We're at the training academy. So I was coming to the training academy several times a year, training new recruits on mental health first aid, on just various aspects of how to function in their job, doing emergency petitions, taking care of themselves, resiliency, those kinds of things. So then now my face is here, and it's not such a scary thing to go see this sort of unknown person, because it's somebody that they're used to seeing around in the halls. And we really, and I think because of that, that sort of helped kind of solidify things within the department. It wasn't just Steve, it wasn't just peer support, it was here's this person that's just sort of around and is, could be deemed trustworthy in that regard.
And as part of the culture of the department in 2015, again, when you look at the timeline, Steve worked with me and some other clinicians at Crisis, but we trained the entire department in mental health first aid, which was really a big step. With that, we've also have almost 20%, I think we're 17, 18% of our departments trained in CIT, in which Steve is a principal, I don't want to say trainer because he's not always there training, but we're there. We have in our CIT, the 40-hour CIT training, we have a lot of outside instructors, but Steve is there when we go on site visits. He's there with officers, because again, the same officers that a lot of times that are interested in attending the 40-hour CIT also want to be trained in the 30-hour group and individual for CISM. And there's that the relationship building that they know Steve, they're comfortable with Steve, and they can reach out to Steve with, and as they refer clients to Steve.
So how it works now is obviously I can't see every single person that calls me. And that kind of on my end got me to start working with the clinicians that work in my practice and kind of saying, hey, are you interested in seeing this population? Are there things that, do you think this is something you might like to do? And so many of them said yes. And with that, many of them already had sort of training and working with law enforcement because they either worked with mobile crisis or they had been working around me long enough that we sort of talked about cases and things like that. And then I developed a sort of kind of basic training for clinicians. And that's kind of what I do now with them if they're interested in it. And then I consult with cases from here and there. But how it works now, it's again, not really scientific. If Steve or someone else in peer support has someone who is interested in seeking mental health services, they reach out to me directly or they reach out to the practice. And typically, because of the way that we set things up and how we train folks and within our practice, they are able to see a clinician within a week most of the time, if I can. And now, it waxes and wanes in terms of ability, depending on, what they need to be seen for, because our practice doesn't specialize in everything that law enforcement does or everything first responders do. And we're not always the best fit, but sometimes we can be. So again, not a big mind-blowing kind of something. It's more of a handoff at this point. But it took us a while to sort of kind of get there. So what are the strategies that we do to make this work? What I really suggest on the provider end is getting involved in mobile crisis team in some form or fashion. Almost every jurisdiction in Maryland has one. Not all of them are police-based, but many of them are. And with that, you've got a unique lens or view into what it's like as a clinician, or what it's like as a first responder. To be there on those calls. I can tell you that I have plenty of officers that come in and they're throwing out 10 codes and they're doing this and they're telling me about a call they went on. I'm like, yep, been there. I was there. I wasn't necessarily I wasn't an officer on that call, but I was there as a clinician, kind of experiencing the same thing with them. One of the biggest recommendations is doing a ride along, because again, you're going to get your face there. You're going to be present with them and you're going to be able to experience that. Another really important key, I think, for providers is to attend an ICISF training. There are tons of them, and I can tell you that the first time I sat down and did basic crisis intervention and group crisis intervention, I was like, this is so boring. And I don't mean that in a negative way, but as a clinician, you're trained in a way that, like, most of the information that's delivered is information you already got from your graduate program. So it's not necessarily geared directed towards clinicians, but what I can tell you is it helped me frame how I intervene in various crises with first responders and other people. And it also, again, created that network. I was then exposed to a larger group of people from lots of different areas, kind of getting exposure with other first responders. So they say, hey, there's a mental health clinician and this is what he does. And then, hey, there's this person who works in this peer support program. So it was really, really important, I think, as a provider to do that.
So I think it's important for first responders that we have to do our research and know who the providers are. What is their specialty? Do they understand like Steve just talked about, for him being a mobile crisis clinician, he understood the police culture, but does the clinician understand the police culture? Do they understand why we do what we do, why certain procedures? So you have to get to know who the providers are. Do they understand trauma? Do they understand first responder trauma? Steve is sort of my go-to, that I'm calling him all the time, and I get my sort of free counseling on the phone, but it's that being able to understand what officers are, what's happening, and how the relationship between the officer and the clinician works. And again, when we do our ICIF trainings, we actually they're open to the community as well as first responders. And that mix is really important, because the clinicians get to see what we're doing in Anne Arundel County and how we are helping officers. And again, it's that culture of helping, that we're expected to assist the officers the same way the officers are expected to assist the community. And by having the peer support program, Steve helped me write our SOP, where we go through and the framework of following the teachings of ICISF and CISM of how we're helping the officers.
Yeah, and from a first responder kind of side of things, I cannot stress how paramount peer support programs are. They are the first line of defense when it comes to helping people out. I am not a firm believer that everybody needs to go to counseling. I think a lot of times you can just sort of deal with things in-house with a peer, with someone who's trained to listen. And it's a really good strategy and kind of helping keep the wheel greased, right? How to keep people functioning, keep people at work, keep people healthy. And because of that, that having a peer support program, no matter what department you're in, I think is just paramount.
And an example of, there are not enough clinicians to see every officer that's been involved in a traumatic incident. I can assure you that from our response to the Capitol Gazette shooting, the amount of officers that were exposed to trauma is overwhelming. There are not enough clinicians for that. So when we can, really the goal is to have the peer trained to provide the support, and just be there as a good listener, but also recognizing when someone does need additional help.
Also for providers, it's really important, I think, to accept insurance, because it's not cost effective to pay out of pocket for insurance these days for a lot of people, especially those in the first responder community. They're going to need to use their insurance. So if you can, you should. So where have we messed up? a lot of places. On the provider end, not doing research on your department, so not understanding what, if you're embedded in a community, what is the department that's running your community? They're just sort of, yeah, I want to do that. Overly eager. I have met many clinicians, and I've had actually lots of clients who've come to me who said they had seen a provider previously, and they were mostly interested in the stories. That's all they sort of kind of got most of their excitement vicariously through the first responder, and by way of that, they actually weren't helping, and it created a different dynamic in the room for them. I can tell you that fit for duty is a huge, but has been a huge mistake in the past for us. I am not a fit for duty psychologist. I want nothing to do with fit for duty. And the reason that is because I want first responders who come to see me to be there voluntarily, and I want them to be able to express themselves no matter what, without me having the edge of their job looming over the situation. I've been caught in those situations before where command staff wanted letters from me saying that they were okay to work. I will not do that. In those cases, I encourage the department to find a fit for duty psychologist who is trained and specialized in that. I am strictly a therapist here to help. I'm in no way, I do not want to have any bearing on their job. Another mistake that I made one time was who's in the room. So I had a client come to me pretty quickly after an incident. And again, the department's really good. They want people to get help, and they brought, and so a whole cavalry came with this person because they were really concerned and supportive of them. And they came up to my office, and it was several minutes in, I'm talking to this client, this other person is sitting in my room, and I'm going, and who is this person to you? And it turned out it was his supervisor. And I was immediately, taken aback, and I did not realize that was happening, and I didn't ask the right questions in time, and so I had to ask him to leave, because that's who wants to have their initial counseling session with their boss present, and I didn't ask him the right questions at the time. So I mean, I quickly kind of squashed it, but just remember, figure out who's helping this person too, and what they're doing there. And I think and it wasn't negative. The intention was to be supportive of him and to help him. But on my side of things, it really wasn't a good situation.
So when you start looking at it from the first responder side, not doing our research on the provider, is the provider trained in trauma? Do they understand the police culture? Not just that, what is their motive? And there are times, and we've seen times where providers have said, hey, we'll come in and actually do it for free. We'll give 5 sessions for free to someone. But then what do you do in the 6th, 7th, and 8th session, or the 20th session? So, and again, it's how does that work? The fit for duty can be a problem, because we'll have an incident happen, and supervision, command staff could see that someone's visibly upset and shaken, and want the peer support program to be the fit for duty, and we have to let them know that's not what our responsibility is. For the fit for duty, that psychiatrist doing fit for duty, their interest is in the safety, or really the liability of the department. What we're talking about for what we do is the care of that person, the officer looking at them as a person, and what are we doing to help them without them being afraid that they're going to lose their job. And it's important to look at recognizing that there is a difference. So poorly managed peer support programs. Is there a structure in the peer support program? And some problems that can come out of it is if confidentiality is broken. We also, there's a difference, and you have to know what the legal standard in your jurisdiction is between privileged information and confidentiality. You can sit and say that everything is confidential, but you may not legally have it be privileged where you can get called into court on what is being said. Another part is, and this goes against what critical and stress management is mandating someone participate. And we cannot do that. It's just everyone voluntarily participates in our one-on-one interventions as well as in our group interventions, whether they are going through a debriefing or if it's just giving information.
It's also important to sort of, again, manage expectations all around. And when I say who pays, I've certainly been called into situations where it's, this guy just needs help now, right? And payment wasn't discussed up front with anybody. And I work with insurance, and so I've certainly done a handful of free consultations here and there, especially for people who are in crisis, where they need something very quickly. But I've had a situation where I had somebody who came in and wanted help, and because their situation was directly related to something at work, they just sort of assumed the police department was footing the bill. And I said, no, you're here on your own volition. The department's not, I don't have that type of relationship with the department. I don't want that kind of relationship with the department, because then they might have some more say over what I do or what I don't do. And so that became a sort of, it was not, it didn't disrupt the relationship, but there was definitely something a hurdle we had to get through. So kind of making sure that everybody understands in your partnerships who's doing what and how are funds being used.
And I think it's important to hit on that because, at times police officers are cynical, and it's going to be looked upon if the department is paying, who is the clinician accountable to? Is it the person or is it the department? And in our model, anyone that's seeing Steve or going to his practice knows that they are interested, it's their benefit. It's not there, and it goes along with the fit for duty. They're not there for protecting the interest of the department. They're there to help the individual officer as a person after the incident.
So what do we find as best practice for this? Really, the number one is buy-in. Having buy-in from the frontline staff is actually, in my opinion, more important than the command staff, but having the command staff buy-in is also really important, at least sort of closing the gap on both ends. But if you have, I can tell you that for many of the people that I've seen, if they're open about coming to therapy and they talk to other people about it, it kind of reduces that level of stigma and makes it more normal. And the more normal it is for everyone, then the more normal it is just as a general practice. I have a handful of officers who see me that actually are friends with one another, and they're pretty open about talking about it with others. So having that buy-in, I think, is really important, that receiving mental health care as a first responder is just as normal as going to the doctor when you have a cold. That's really kind of what the hope is around this, particularly in first responder work, because of the acuity and the nature of the work that is conducted. Go ahead.
And I'm going to add to the buy-in the significance throughout the command staff as it becomes part of the culture. Again, the culture of helping, the culture of being there to help the officer, like we do the community. But it's all the way through the command, because it's that sergeant recognizing or lieutenant recognizing that, hey, this was a bad incident. How about someone from the peer support team come out and address our lineup? So I said earlier that we responded to the suicidal death of a 14-year-old yesterday. One of our peers was at that lineup today talking to the officers, and especially the officers that were doing CPR on that child that's deceased, and recognizing, okay, if everything goes as planned, there isn't going to have to be a referral to Steve. But if there is a referral, it's important that the supervision recognizes that that's okay, and it's okay not to be okay.
Yeah. And so moving on to flexibility, I mean that in around how and when a provider sees clients. I've actually, in a really high profile situation, went to somebody's home one time with another crisis clinician, just to start that relationship with them. I'm not saying that that's what a clinician should do, but I was flexible around it in that particular instance. For clinicians, it's really important, I think, in my opinion, that you understand the flexibility and the nature of the job. In Anne Arundel County, they work swing shift. So those who work day evening are on a week of days, a week of nights, a week of days, a week of nights. So, and particularly in my practice, folks are typically scheduled same day and time each week. I explain to my clinicians, it's not going to work for your first responders because they work different hours and different shifts. So I try to make sure that I can be flexible in when I can see them, day or evening. Yeah, and then being fluid, always being open to sort of changing how the process works. There have been times where, I saw someone and it didn't work for a number of different reasons. I had to go back to Steve or the referral source and say, hey, here's why this didn't work. We either don't see this type of issue that's going on here because it's X, Y, and Z, or here's what would have worked better. Certainly, I also had situations where people didn't have a good understanding or expectation of what was going to happen when they came to see me, that I had to sort of monitor and then kind of go back and say, hey, when you're communicating with them, make sure you understand that here's what we do here, because they didn't seem to understand that. Practicality, what I mean by that is not, like I said earlier, not every first responder can come and see me. Not every first responder can come and see the people in my practice. And that's not just because we can't see everybody, but sometimes it's just not a good fit. And that's okay too. I have another friend who is with ICISF, who runs another practice that sees first responders, and we had talked and consulted one time, and he says there's no shortage of a business, so to speak. So it's not that we need to compete with one another. It's not that I'm not the only game in town. There's plenty of places that people can go to, and plenty of things that they see fit. I've had people who've come to see me who didn't like my style or didn't like me, and that's totally okay. And so I found a referral for them elsewhere. So just kind of remembering that, from at least from a clinician side and from the first responder side. I have to tell that to Steve too. He'll try to make a referral, and I say I'm either full or I don't see that type of issue, or we're just not always able to see everything all the time. You're going to have to find somewhere else, and they do. There's other places too. Logistically, making sure that you have, as a clinician, a timely referral. Like if somebody needs to be seen, try a month out, 2 months out, it's not going to work. Try to see somebody within the week, 2 weeks if possible. Try to figure out what type of services that are needed. Are you in a location that's practical for people? It's not so much an issue now with everybody being virtual, but when you're in person, like are you at a place where people can be seen?
And if I can add to that, Steve does a great job too of people that no one knows who he sees unless they want someone to know. So he does a great job of scheduling and having so officers do not run into each other in the waiting room, which is really important, because there are people that see him that no one knows that they see him other than him in the person. So that confidentiality is really important, and he does a great job with that.
Yeah, that's a really good point. I forgot to mention that. Yeah. So if you're seeing officers back to back, or you're in there seeing a lot of people from the same department, you want to make sure you honor and respect their confidentiality. And so I'll try to find a way to make sure that people don't cross paths if possible. Training, there's always training. Be on the lookout for training, both again from a first responder standpoint, where you can get more training and providing mental health care, peer support, things like that, and from a clinician standpoint, learning on how to work with first responders. Peer support and clinician competency, that is super important. I don't really feel like you can just come out the gate and be good about this work or know how to do this work without understanding what you're getting yourself into. I know when peer support first started, I had a client who said that the person they talked to who was on peer support ended up saying things to his supervision, which led to him getting in trouble for a couple of different things, and he was untrustworthy at that time. He's been able to work through that, but that was something that happened. That was kind of a fracture in the system. Okay. So where did this work? I can tell you that it worked pretty well for me anyway. When we were involved in the Capitol Gazette shooting, I was called to go there, but was not there, which at the time was kind of a panic on my end and a panic on the crisis response systems end, because normally I would be involved in something like that from jump. But it actually ended up working out really well because I was able to then go see people from after the incident. So 2 days after the training, or two days after the incident, I was at my office seeing many who had already either been in counseling with me, or some people who were pretty adversely affected by the incident. It's worked well. I think when we have departmental suspensions, obviously nobody wants those to happen, but they are something that rocks people's world. And I've definitely been able to, I think, effectively treat people in those situations.
Yeah. So anytime someone's suspended, I'm notified, a peer reaches out to that person. So you remember, the goal is to have that, just because they're suspended doesn't mean they're going to be terminated. And we want them to be back as a productive police officer again. And again, it's the same thing, and I keep hitting the same theme. How can we help the officer be a better officer to take care of the community? They know we care about them, and the peer reaches out of how can we help? And if it's appropriate, they're linked to Steve. And it creates that culture of helping within the department.
And you know, numerous post-incident response, I think where our relationship really shines and is effective is after some sort of critical incident. And usually what happens is the crisis team will go in and debrief officers who were on shift or were involved in the incident. And then born out of that, if there's needed, if they need more follow-up or more care, then that sort of warm handoff happens at that point. And many of the people that I see, it's not necessarily I see them forever. You know, it's not a forever type of thing. I had an officer who was involved in an incident who came to see me after it and said, listen, I'm okay, but I just want to talk it through for a little bit. And I saw him, I think, between 3 and 5 sessions, and it sort of clicked for him, and he was good to go after that. So it's not always a long-term counseling situation, although many of them do turn into that way. But I'm happy to work with people from 1 to 1,000,000 sessions if they need be, depending on what the circumstances are. Okay. So moving forward, this is kind of my hope and you know, dreams, I guess you would say. I really like the idea of mental health checkups. Now, if you ask a lawyer or an attorney on whoever's side of this, they don't agree with it because they're worried about the liability involved. But I am a big proponent of first responders doing once-a-year mental health checkups. The same way you go to your doctor for a physical every year, the same way you go to the dentist twice a year, hopefully, that you would go to see a mental health provider once a year just to check in to see how you're doing. I don't think there's anything wrong with self-reflection once a year, and it's, you know, covered by most insurance plans. It seems like a pretty low cost, low investment, but high return kind of something. So that's what I would like to see in the future. I don't really know how that will, when and if that will ever work out in practicality. I'm not sure of other departments that do it. I know many of the organizations that work on first responder suicide prevention also recommend that.
And if I can add, there's a difference between a mental health checkup and a yearly fit for duty. And
Yes.
Again, it's that what is the purpose of it? Is it to help the person, the officer who is a person getting assistance versus the fit for duty, which is a liability to the department?
Yeah. And then in a perfect world, I'd like to see more therapeutic groups among first responders, because I think, you know, one helping out the other, it would be really helpful. It's sometimes hard. It's a barrier for a lot of people because of the confidentiality piece and the worry about who's going to be where and who's going to know. Support groups, I also think we could do a better job at having a lot more of those, even without clinician involvement. And then definitely more training and normalizing this as a process and experience. I strongly feel that every department, fire, police, EMS, whoever, should have some sort of relationship with mental health practices. And it doesn't have to be one mental health practice, because I understand the kind of problem that you can have in preferring one over the other, but building relationships with different mental health practices so that you have places to send people so that they get quality and competent care. I just think should be sort of baseline for everyone. So that, I mean, those are my kind of hopes for the future. Yeah. Anything else?
No, I think it's
good. So that's our presentation. Here's our contact information, and we're open for questions.
Awesome, awesome, awesome. Thank you so much, Lieutenant Thomas and Steve. I love how you pointed out that you're developing the culture of helping. Very important partnerships, and that you're building, and your hope is to build relationships with mental health agencies. So thank you so much. Thank you so much. Thank you for both providing such a critical information during this time of great need. Right now, we'd like to open up our webinar now for any questions that you may have. Remember that every participant will stay muted to avoid background noise, but you can type your question in the question box at the right hand of your side of your screen if you're viewing from the computer, or at the bottom of your screen if you're viewing from a phone. If you have any questions that you'd like to ask, or if you have a comment about the webinar today, please enter these questions into the box now. If we do not have time to answer each question today, we will provide our contact information at the end of the webinar for anyone who may wish to reach us. So we did, as you guys were doing the presentation, we did have a couple of comments and a couple of questions. So I'll start the question, and please feel free to ask your questions in the question box. The first question that we have is, how can we overcome stigma in my area? There's an anxiety about seeing a professional due to past experiences or the stigma associated with mental health, particularly among first responders.
Yeah,
I think a lot of it's training. So like we start off today, Steve and I are together at our training academy teaching mental health first aid. And one of the purposes of the class is not just to have empathy and understanding, but to remove the stigma of mental health. Our goal is that people will openly talk about seeing a therapist, like you openly talk about going to a physical therapist. I tweaked my knee, I tweaked my ankle, so I'm going to get help. Is that any different in practicality than going to see a mental health therapist? So as we continually do education and making it normal for that to be the mentality and not the exception.
Yeah, so I would say to that person who asked that question, go yourself. Go see a therapist yourself, and then be open to talking to people about it yourself. I think there's always a good time to go see a therapist. And to kind of piggyback off of that idea of the stigma, there's a stigma in my field about seeing a therapist. When a therapist, how can therapists see a therapist? I can tell you, I've been seeing a therapist for 5 years, 6, 7 years. I love it. I love every minute of it. It's one of the best things I've ever done. And I find it extremely helpful. And I'm very open about telling people about it. So if you're kind of finding how do you break down some of that stigma, participate yourself and be open about that experience as much as you're willing to. Because the more normal that it becomes, the easier it is.
All right, so before we get started with the next question, we did have one comment. Someone wanted to know if you can put the slide back up that shows the first responders and therapists and how they are similar.
Yeah, how they're similar. Yeah, they are.
Thank you. Mackenzie?
Perfect. So our next question is, what is the best way, and I know we touched on this a little bit with ride-alongs and trainings, but what is the best way to get involved in CIT and or becoming a trainer to help first responders in my community?
So I think it depends on where your community is. So if you would have asked me that 10 years ago, we didn't have a CIT program. because of the buy-in, the strength of our crisis system, we progress very quickly. So I think it's just reaching out to wherever you're at, and if they do have a CIT program, or if they have any kind of mental health within the police department, and first making that connection and building on that relationship.
So if you're a first responder and you're looking to get more involved in CIT, I would encourage you to look to your department if they have one. If not, we run a CIT training program and we open it up to other jurisdictions because we want everyone to have this information and training. And so I would encourage you the next time we do that to maybe reach out to us to see if we can get you involved in that. If you're a clinician looking to get involved in CIT or involved in working in this type of work, it really is, I think, about kind of making connection with the crisis programs in your area, whatever that looks like. But I can tell you that they're always hurting for people. So there's no shortage of need for crisis clinicians. And that's your foot in the door.
Wonderful, thank you.
Okay. Next question. How do we give mental health help to our 911 workers who work 12-hour shifts?
It's actually more than, not just the 12-hour shift. So we have trained some of our 911 operators, call takers, as well as dispatchers. We do go over on critical incidents and do debriefings with them and provide them support. You know, it's at times it's even more traumatic for the call taker and the dispatcher because they don't get closure. And what I mean by that, when a traumatic incident happens, officers are on scene and they know they get a better sense of what the end result is. You could have a call taker on the phone, people in crisis, and then when they hang up the phone, they're expected to take the next call and move right into the next call without getting closure on the call before them. So you're absolutely right, and we need to do more for 911 centers and call takers and dispatchers.
Wonderful. To both Steve, where do you see an intersection between NAMI and your program?
Well, it's really important, and they're critical in our relationship in the CIT program. So for us, Fred Delp is the executive director of Anne Arundel County, and the first day he's there and does a class on what NAMI is and talks about his involvement in NAMI. But also we also have consumers from NAMI and for the class in our own voice. And it's really an integral part of our CIT training is that the personal touch that the officers get from the people telling their story.
Mm-hmm.
Yeah, absolutely.
Okay, we have a couple of more comments and questions. A lot of people are saying thank you and they appreciate the work that you are doing to both of you all. So the next question is, how can we best support you? Do you believe that officers should be in support groups specific to first responders, or would it be better for them to be in support groups that are more general so that they don't get pulled into the focus on the department, other officers, etc., so that the focus is on self-reflection rather than on the department?
Yeah, I mean, great question. I think it's really unique to the individual with that answer. I've certainly had people who've come in who have chosen to bypass peer support and not talk to them at all and just wanted to see me because they said, I'm not talking to them. I want to talk to the professional. I don't want to deal with that. But I do think that there should be more involvement in support groups and things like that. And in terms of whether they should be in a first responder group or a general group, I can see benefits and drawbacks to both. I can see, having a homogenous group of first responders allows, I think, people to feel connected and understood in a way that it would be different if not. At the same time, I often encourage first responders to make sure that they engage with part of their identity that has nothing to do with them as a first responder. because I think sometimes they get so engrossed in their own identity as that if something were to happen, like a retirement or a suspension or something like that, they're drawn into such a crisis because they can't be who they want to be. So I think there is a lot of benefit in being able to go to more a heterogeneous group and seeing things from a different perspective. So it really is individual.
And I was going to say, but it's also, we have to remember it's what's best for that person. And first responders historically have not gone out and sought help. So it's whatever is going to make that person more comfortable getting help. Now, who knows, in the beginning, it may be that they're in that homogenous group of first responders, and later they feel comfortable going outside of that. But it's whatever is more comfortable for them to get assistance.
Absolutely. Our next question is part of counseling police now helping them manage the negative view that much of the country has of them? How do they manage
Absolutely.
the hostility from the population they are trying to protect?
Yeah, that's a really, really good question, and I'm glad somebody asked it. There's definitely been a noticeable shift in the last 4 years and even over the last 12 months in sort of how law enforcement manages their own anxiety around public scrutiny and how they're viewed. And I've definitely dealt with that a lot more, I would say, recently. So there are many different ways that you can approach that, and some of it's more just kind of learning to mitigate your own anxiety and normalizing some of that. That's not just a me thing. That's actually a nationwide narrative that I think most first responders are feeling. And one of the ways that I've really sort of tackled it is really trying to get first responders to understand that just because there is sort of this maybe more negative undertone or narrative in the media does not necessarily mean that that's how everybody feels. And that actually the majority of us fall somewhere in the middle and can see multiple different sides of how things have progressed in our country over the last years. And I think that way about most things that we see in the media. And so kind of understanding that most of us are somewhere in the middle with how you view law enforcement and first responders. And the other thing I really try to get people to do is don't engage with that larger narrative, because you don't have the impact on that large narrative as an individual. What you have impact on is you that day in that situation. That's what you have control over. So I really encourage officers and other first responders to wake up that day and recommit to your mission. What is your mission that day? And maybe it's different every day, but wake up, recommit to your mission, and remember that you're there for the folks that you're not interacting with. You know, a lot of times we forget that because we're working with more negative parts of the society or more contentious or struggling parts that a lot of times we're there to assist with the people that we don't interact with. And I found that to be quite helpful.
And I think this is really important to be part of. This should be part of police reform. It really to create that culture of helping and not to be hurtful. And again, we help each other within law enforcement just like we help the community.
Wow, thank you so much. Thank you. And I think that's the last of the questions. Thank you everyone for joining us. As a reminder, this webinar has been recorded and will be emailed to registrants tomorrow. The webinar will also be uploaded to our website at namimd.org for any individuals who are unable to attend today. We hope that this webinar has been helpful for you this afternoon. At the end, you will be asked to complete a short survey on the aspects of this webinar that you felt were helpful, could be improved, and what you would like to see in future webinars. 1 hour of CEUs are available for Maryland Police, Corrections, and EMS professionals. Individuals pursuing CEUs must submit this survey. Each person that completes the survey will also be entered into a drawing to win a $25 Amazon gift card. This is only one webinar in a series of educational webinars that NAMI Maryland plans to host. We plan to host 3 more webinars between now and April surrounding topics of creating a peer support team, cumulative trauma, and compassion cultivation. This survey will help determine how NAMI Maryland can best support you during this time. Our next webinar is entitled Creating a Peer Support Team for First Responders and will take place on March 8th from 12 o'clock to 1 o'clock p.m. Mackenzie will include the registration information in the chat now for anyone who may wish to join. By being an attendee of this webinar, you are also invited to join us for our NAMI Walks, Your Way Maryland campaign. NAMI Walks is the nation's largest and most successful mental health awareness and fundraising campaign. NAMI Maryland has been involved in NAMI Walks since the very beginning, and we invite you to join us for what will no doubt be an incredible virtual experience. There are many ways you can make a difference with NAMI Walks as a sponsor, a team captain, team member, or individual participant. However you participate, you are joining a national movement to reduce stigma, spread awareness, and support NAMI's mission here in our state. You can join now for free at www.namiwalks.org/Maryland. We wish you all a safe and healthy rest of the week. And please do not hesitate to reach out to us through our website or by phone at 410-884-8691. Should you need any additional resources and/or support. Have a great rest of your day. Thank you.
Bye, everyone.